Okay, so today our main focus is on our WSIC dashboards and how they can help you deliver the focus on methodology. Just going to go through the running order of the day. So this is what we plan to achieve today. This is quite ambitious. I'm hoping that we're going to get through it, but I'm going to hold everyone to task to make sure that we get through a little bit of this as we go forward. So I think, first of all, I'd just like to introduce myself. My name is Matthew. I'm the Head of Population Health Management for North West London ICB. Rachel C, would you like to introduce yourself?
Hi everyone, I'm Rachel and I'm a Population Health Analyst and I sit in the Health Equities team within the ICB.
Brilliant. And Rachel Mack.
Hi everybody, I'm Rachel McCarthy. I'm the Business Analytics and Deployment Lead for BI in North West London.
Great, thank you. Okay, Rachel, shall I just hand over to you? Do you want to give us a bit of a plan for today's session and the...
Yes, so our plan for today's session is we've got kind of four different things. So Matthew's going to take us through a bit of introduction. I've got some questions so we can gather a bit of feeling about how people feel and when they use the WSIC dashboards. And then Rachel's going to go into a bit more description about what the WSIC dashboards are. And then we've got a really good example of how to use the dashboards when thinking about cervical screening. Here's the next slide, Matthew. So what we're hoping to achieve is for people to understand why PHM and good data cells, PHM being population health management, are important, particularly in the context of the Model ICB blueprint and 10-year plan. How we link the focus on methodology and how this links to WSIC. A better understanding of what the WSIC dashboards are and how we can access them and how they contribute to planning and decision making, and who to go for support. I think I'm handing now back to Matthew, who's going to do a bit of context setting for us. You're on mute, Matthew.
Sorry, I didn't know why I was doing that. So ultimately, what we're trying to do here is start a conversation, really. I'm going to whiz through this reasonably quickly because obviously there's a whole conversation around well, what is population health management? Why do we need to do it? How does it help us deliver the things that we need to deliver in our day-to-day jobs? And particularly in the context of the 10-year health plan and the new model ICB, which I've got links in here. I'm not going to reference them too much, but really it's just around understanding what population health management is and how it links with it. So, the way that we've tried to describe population health management in North West London is that fundamentally this is about taking action, and it's taking action with a predominant eye on about how do we reduce health inequalities in our footprint, and it's about using data and intelligence-led insights. And I want to really be clear about this. Is not just about hard data. This is about how we use intelligence. So a lot of what our communities tell us, what are some of those qualitative measures, what is the intelligence that we can generate from both hard data and softer data to inform targeted interventions, help with our planning and help with our decision making. It's really around embedding evidence as well. So this is really around are we doing the right things? How can we tell? Where does research fit into understanding what we need to do, and how does that link into the wider idea about we're doing the right things by our populations? And as we talked about health inequalities, we can't forget around the wider determinants of health. So this is not just about healthcare. This is really very much around understanding that a person is a holistic entity, that often their health needs are only about 20% of actually their presenting needs when they're accessing services. So this is really around understanding those wider determinants. It's really around us coming together to use our collective resources to deliver change in an impactful way, and making sure that we collaborate with our communities in order to do that. So that's essentially how we're describing population health management. We know that it's been evidenced to be impactful. So this is part of the reason why we really want to drive it forwards. It's part of sort of our national structures around how we sort of deliver impactful and evidence-based interventions. Not going to go through this slide too much. You will have access to them to afterwards. Please do go and have a look at them. And just to reference again, not going to go into too much detail about the 10-year health plan, very, very eagerly awaited, but it talks a lot of about things that are sort of really fundamental to sort of like good population health management, around sort of how we do things in partnership with our communities, how we take a data-led and an intelligence-led approach to how we do it. And a lot of these things are sort of also very much reflected in the new model ICB blueprint, but that goes into a little bit more granularity, a little bit more data around actually what that means. So it talks very much around sorts of the types of data, the types of intelligence, how we need to sort of implement them as we move forwards into strategic commissioning. So population health management is very, very, very fundamental to sort of how we take forward our service delivery. And the relation to WSIC is one of the cornerstones around population health management, is that it is a data and intelligence-led way of thinking.
You've gone on mute again, Matthew.
Sorry, it just does that scene every time I change slide for some reason. I think I've got something wrong in my settings, but just say, I'm not going to talk about this very much, but this is one of our methodologies of how we want to encourage people to sort of think about how do they embed population health management in their work and practice. Really happy to sort of like pick up this conversation outside of this meeting or have a separate session on exactly what this really means. But I pulled this out because I really wanted to show the impact of data and the role of data in how we deliver population health management. And essentially what we say in population health management is the process to deliver it really effectively is to find your areas of inequalities, use data and insights to sort of identify where you think you want to sort of do the work. Then go and have open conversations with your communities and those who are sort of affected or potential users of those services. Design and co-create some ideas around what you might want to do in that space to sort of deliver services or interventions, and then just like unite your ideas around sort of a small subset of ideas. Go away and do it, test it, does it work? And then sort of you go and sort of measure it in an integrated way, so like as part of an ongoing measurement package, and then you come back to like analyze it. Has it done the right thing? And where data really, really picks up, and it should feature through all of these stages that I focus on, but it really, really has most importance, particularly in that beginning bit of finding. So data and intelligence is really around like finding your communities, finding where the need is, finding what you want to investigate, but also very much is part of that sort of study. Are we doing the right thing? What's the evidence? What's the data telling us about whether we're doing the right thing in our population health management approach? And again, it's a key part of that ongoing measurement. So key message here is we have a methodology to deliver population health management. It's very simple. Most people will be familiar with this concept, even if it's not set out like this. Data is an integral part of how we actually take that forward. It's got some very key areas where we'd want to deliver that. And at that point, I'm going to hand back over to Rachel, just around getting your thoughts around dashboards.
Yes, so thank you, Matthew. If everybody could go to menti.com and either enter the code or use the QR code to access the questions, and I'm just going to now see if I can present slides.
Do you want me to take this down?
Yes, I think I am now. Oh, am I presenting?
Looks like
it.
Okay.
Okay. Yeah. It's great because I can still see the screen, and that's the link. If people don't have it, I'm sorry, I've got double QR code on this, but hopefully people can use the code and the link.
Ali,
Hi, Rachel.
Ali.
Yeah, just to say, I had it up and then it just now says you're all set, waiting for a presenter, and I can only give you a thumbs up, but I can't actually vote on the cutest kitten, which I was loving.
Oh, well, that is coming up. Spoilers.
Oh, sorry.
No, I think that's how it should be.
Okay.
But let's see. Okay, well, I think we have got a critical amount of people. So, oh, and I see some people have already voted. So obviously the first and most important question, just to get everyone warmed up, is please can you vote on which cat you think is the cutest? Okay, great. Oh, it's changing now. More people have different opinions. I'm surprised 11 is the one who's winning. I think that one looks slightly AI.
Rachel, when you were pulling this together, I did say there needs to be a category 5, which is all of them. I was like, how people are choosing, I do not know.
Right.
See, now I just feel very sorry for cat number 2, so that's the one I want to take home now.
Yeah, cat number 2 does look quite sad. So, okay, well, it looks like we do have a winner, which is cat 3, but you know, obviously all these kittens are cute, so I won't say that they're all winners. Okay, so next question is what comes to mind when we say dashboards? So I'm just trying to get a feeling from people about what they think when we say dashboards. What do they think of, and how do they think it might be useful to them? Okay, great. Yeah, data is definitely a key one. Graphs, data visualization, out of date. Yeah, okay, this is really good. It's great to get a feeling of what people are like associating with the dashboards, just general dashboards and ones that we have in the ICB. Okay, these are, I feel like this is great. It's mostly positive, mostly just very information led. Confused. Great. Well, there's some, yeah, good things there about kind of visualization, looking at trends, understanding the numbers, interactive, visual. And I think these are all things we really want our dashboards to be. I mean, ideally, we don't want them to be confusing, but this kind of comes, leads into our next questions. So, but we'd just like to get an idea of how often people are using a WSIC dashboard. It feels like it's a little at the moment. It looks like it's a bit divided between people never using it and people using it very frequently, so every day. So that's quite interesting that we've got sort of a mix of people here. I'll just give people a couple more moments to fill in their answer because it's really useful for us to get an idea of how often people are using these dashboards. And of course, there isn't sort of a right answer. You know, the dashboard is needed as much as you need it. So if you need to only view something once a month to pull it into another process that you're doing, then that's obviously exactly the right amount for you. Okay, great. Looks like the numbers are slowed down. So is it very interesting to us that the majority answer is never but would like to? And so I would like to know from those people, but also people who are using the dashboards, even if you do use it, is there anything that you find difficult about using the dashboard? So what's holding you back from what you're doing? And you can put multiple answers in for this answer, hopefully. Yeah, so I've seen quite a lot of people have put another problem, so feel free to put that problem in the chat, or there will be a bit of a free text question in the next couple of questions, which you could put in there as well.
Rachel, Kieran's just mentioned that she's only been able to select one answer, which if that's the way it is, that's fine, but feel free just to put more information in the chat if anybody's got any feedback specifically that they would like to share with us.
I'm not sure I can change it on the fly. That would
I think we've got a little bit of time at the end of the session today, so if we were to round back on this, I think you're particularly understanding another problem is one of the big areas. It'd be really lovely to know what some of those are.
Great. I'll give people just a couple more moments to put in their answer. But yeah, it seems like the biggest one out of the categories is that the dashboard is difficult to navigate. So that's good to know, and yeah, something that I think, you know, they tend to be quite all the dashboards I think are quite, there's lots of different options you can choose. So I think that the more detailed something is, sometimes when we're presented with too many options, that makes things more complex. And yeah, so any of the other problems, please either put in the chat, or there will be an opportunity in the Menti slides. So for the people who do use the dashboards, or for people who aren't using them but would like to, I'd like to know what you'd like to use the dashboards for. So what sort of decisions would you like that for you to assist with, or what sort of different processes? So do you want to use it to help you put information into business cases, or helping you find patients? I think you can put everything, so please yeah, let us know. Great, so there's definitely a focus here about understanding population, and so yeah, I can also see something about identifying inequalities and looking at ethnicity, and looks like feeding into business cases is a big part of what people want to use the dashboards for. And yeah, I see a bit of monitoring and KPI delivery, and that is, you know, also a really good way to kind of monitor how things progress. I think what I find interesting here is that, so data on my population now being the biggest one, that isn't like necessarily a really specific thing. That's just sort of understanding something maybe quite holistically, which sort of speaks to maybe how we need something quite flexible to work in sort of a number of situations. I think there might still be a couple more answers coming in. Okay, great. And I'll now just move us to the last question, which is a bit more open-ended. And I will keep this open for the rest of the session as well. But this is, what can we do to help? So how can we assist you to using the dashboards more effectively, whether that be using it more frequently, whether it's understanding it more, access the information that's held in there. So please, in this bit, put any sort of either problems that you can answer before in the last question. And yeah, just I think you can put this is pretty much free text, so please let us know.
Brilliant. I can see some really interesting stuff coming through already, which we will come back to towards the end of the session as well. But as Rachel says, she's going to leave this open for the rest of the session today. Please do let us know. We'll also sort of try and pull out some of sort of the comments in the chat as well, just so that we've got a really comprehensive view. But yeah, please do contribute to this, because this is how we help. This helps our thinking into like what we need to do going forward. So yeah, please do keep the comments coming. Rachel, Matt, I think it's over to you now. Let me share up the slides, and if you want to just take us through the WSIC dashboards, just bear with me 1 second while I share. And can you just let me know when you want to go on to the next slide?
Will do. And Matthew, if you could let me know if I'm running out of time, that'd be great.
Right, absolutely. We're actually 34 seconds ahead of time at the moment, which is amazing.
I'm fairly certain I'll utilise that. Anyway, I introduced myself earlier, but just for those who have recently joined, I'm Rachel McCarthy. I'm the Business Analytics and Deployment Lead for North West London BI team. Specifically going to talk about WSIC data and dashboards today. So Matthew sort of also touched upon this, but I want to make this really clear that across our ICS, we have 4 objectives, and they are to improve outcomes in population health and healthcare, to prevent ill health and tackle inequalities in outcomes, experiences and access, and enhance productivity and value for money, and support broader economic and social development. So for each of these 4 objectives, it does require a data and digital piece as foundation, and that's what we're here to support with. Now, in North West London, we have WSIC, and we've had WSIC for about 10 years now, and this is really our North West London tool to help support in these objectives. So Matthew, next slide. So thinking about that, we've got WSIC, we've had it for 10 years, there's lots of data coming into it. It's a longitudinal data set, and we create dynamic dashboards on top of that data set. So this helps us as an ICB and an ICS in multiple ways. So those purposes for those dashboards in the data set include to identify the patient cohorts for case management and case finding, to enable recall and integrating lists back into clinical systems, identification for health inequalities which helps with appropriate interventions, enable multidisciplinary teams to work together on the holistic view of the patient's information, of their health and social care information, enabling better patient experiences as healthcare professionals are able to work more closely together. It helps with better health outcomes for the population. It helps reduce a number of emergency activity and be able to work more proactively with our population. And of course, finally, is staff being able to work together to deliver a more joined up healthcare approach. Next slide, please, Matthew. So WSIC has approximately 99% of our North West London registered patients in the WSIC data warehouse. And this slide here gives us a solution, sort of a diagram of what is WSIC all on one page, which is obviously quite complex. So it is, you know, WSIC is large. The data that we bring in is a lot of data, and therefore it's very complex information within the data warehouse. We receive data from a number of different care settings. So we've got at the top of that diagram there, we've laid out a few of those different care settings, like the local authority, community settings, GP practices, hospitals like acute mental health, etc. So there are a number of different care settings. And behind all of WSIC, we have a very robust IG model, which allows us to bring in the patient identifiable data from each of these different care settings, and using the NHS number, links that all together. And this is what gives us that joined up data approach. So on top of this data, we then apply a number of different algorithms. So things like long-term condition. So of all that information that we've received in the data warehouse, then we calculate on that data to work out maybe somebody who's got COPD or asthma or AF, hypertension, and so on. We also use algorithms such as the electronic frailty index, Q admission. We create a Northwest London patient segment and risk segmentation, and all of these sorts of things are used to help categorize and segment the population into groups of patients that you are interested in, or particular groups that are being looked at. So that seems a little bit sort of high level at the moment without a real explanation, and that's what we're going to look at later with Narinda. So all that data and all that information is then available in two ways. So it's available on the identifiable and also on the de-identified. On the identifiable side, we present the identified data back in dashboards. We have integrated patient summary, so like individual patient pages that will give an overview of that patient and show particular health and social care metrics about that patient, just one at a time. We also have case finding tools. So this might be where we use some of that, those things that we just mentioned, like the EFI, risk segmentation, patient segments, that sort of thing. So we help start to find different groups of patients and look at specific metrics that align with those different types of groups. And finally, we also use we have quite a number of long-term condition specific dashboards. So we might have a dashboard on asthma, on diabetes, AF, and so on. There's quite a number of different long-term condition dashboards in there. And the reason that we have those specific ones is through working with the different programs in the ICB. So if we're working with like the respiratory teams or the diabetes team, the cardiovascular teams, these are the dashboards that they have designed, and they said, right, this is the dashboard that we need to be able to see for our cohort of people that we are interested in, that we want to make change to, provide better health outcomes to. And we don't just need a list of those individuals, we also need to see against each one of those individuals a number of different metrics and what those different health and social care outcomes are against each one. And those types of dashboards is what we call radars. I'm not going to delve into too much detail on that today, but in a future session, we will be looking at radars in a bit more detail. So we'll come on to that in the next session that we put on. Sorry, Matthew, back one. On the other side, we have the de-identified, and this is where we get to see things like the population health dashboards or dashboards created for benchmarking. There's a lot of use cases here around analytics. So it might be good for operational analytics, commissioning analytics, public health, and population health as well. And this is either presented in the dashboards, which again are designed by each of the different programs across Northwest London, or the de-identified data set, which is solely available to the analysts and the researchers to be able to do that specific bespoke analytics, where the dashboards may not support the particular questions that have been asked. The de-identified data set is there to support that. Next slide. So I'm sure a lot of people will have spent time with me before in other meetings going through all of these different data feeds. So I'm going to very quickly move through these, but this is the information that we are collecting into WSIC. And what we look at here is where's the data coming from? So the care setting, which providers are providing that data. There's sometimes multiple different data sets available from each area, from each care setting or provider, and the frequency of which that data comes to us. So when we start with primary care, we are receiving data from each of the different practices in Northwest London, bar 3, who haven't signed up. And we receive all of their coded data on a daily basis. Okay, there's a 1 to 2 data lag, and what that means is that data that was recorded yesterday comes to us overnight, fed into the dashboard today. Dashboard is refreshed today with the latest data. So the GP data, which is coming from EMIS and System 1, is one of our most frequent data sets, most up-to-date data sets as well. And where we are using that in a dashboard on a daily basis, those dashboards get refreshed daily. Then we've got acute. We've got a number of different data sets coming from our acute providers. Some of those you can see there are monthly, and it's actually monthly in arrears. So we've got the service level agreement monitoring, known as SLAM, and the secondary use the service data set, which is known as SUS. Both of those are coming monthly in arrears. Those are national data sets, and that is the frequency of that data that comes in. But we also, on top of that, receive weekly and fortnightly data from our acute services. So that brings in more frequent data. So as we are refreshing those dashboards on a more frequent basis, you are receiving that data more frequently. There's additional information there from acutes as well. But I wanted to be clear, you know, sometimes we think, oh, okay, we're only receiving data from our hospitals in Northwest London. That's not quite true. We also receive our out of area acute providers data. So we get that SLAM and SUS data for any of our patients who might go to a hospital outside of Northwest London. So we have that joined up into the data warehouse as well. Next slide, please. Community data. Again, a number of different data sets there and different frequencies. So you can see there we've got the SLAM data set. It's coming in for community. But additional to that, a lot of our community providers have System 1 or EMIS as well. That means that we can get that daily data in to WSIC too. So where there is data being recorded on System 1 or EMIS for the community providers, that's coming in daily and it's being refreshed daily too. We've also got the post-COVID assessment data and looked after children's and SEND data coming in. Well, the looked after and SEND data comes in monthly. The post-COVID assessment data is fortnightly. Mental health data, SLAM data again. And we've also got the direct data feeds like we did with community and primary care from EMIS and System 1. Those are coming in daily. We've got CYP mental health data from CNWL included too. And of course, I've mentioned this a few times now, we don't just have health data, we've got social care data too in WSIC, and this is all being linked in. We've got adult social care data for the 8 local authorities. That comes in monthly. We've also got child in need and looked after children's monthly data. And we've got more detailed data for children's, which is the SIN census and the SSDA 903, which includes looked after child and child protection plan data. It's very granular data. It comes in annually, and currently we just have it for the 3 boroughs, which is Harrow, Kensington, Chelsea and Westminster. But this year we're working through with the other 5 local authorities to bring in that same data so that we have that completed for North West London. Next slide, please. So we have other data sets too, and this is it's sort of a high level of the additional information that we have in here. So we have the national reference data. So there's things like we include the deprivation deciles, and that all links to the postcode registered with the patient. We've got pollution data from SASU. We've got for the research purposes, we've got consent to contact register that comes into WSIC. Anybody may or may not have heard of Remora. It's a rheumatoid arthritis survey. It's a pilot that's running through Northwest London. That data is coming in on a daily basis at the moment. We've also got the lung cancer screening data coming in monthly. We've got some housing data that's available to us, such as the EPC data. So that's coming in on a monthly basis, a month in arrears, that one is. And we've got the London Ambulance Service has shared their frequent callers data. But as Ali mentioned in the chat earlier, we are trying to bring in more LAS data. So this is never a, this is how we are, and we're going to stay like this forever. We're always growing these data feeds. We have quite a number of additional smaller data sets that come in too. So we've previously brought in patient survey information from Futures. We've had CQC data brought in, and so these are things that we bring in for specific purposes. They're used for a particular use case. Both of those examples were used within primary care, within a larger piece of work. So there's more that we can always do. The fact is that we have a framework set up that allows us to be able to do this reasonably quickly compared to a number of other areas that try to do something similar. And the way that we've set up the security within WSIC means that we are able to link this all into data and use this across a number of different levels. So from that population health, de-identified side of things, right the way down to the individual identifiable patient information. Next slide, please. Great. So spend just a couple of minutes on this one, because I think this is really important for us to take away as a, how do we do this sort of thing? All of that information, all that data, what happens next? How do we get this eventually out to you for you to use in the most appropriate way? So on here, this shows how WSIC is set up as a trusted data environment, but it really shows how it takes on this bit of a life cycle approach with regards to what data do we have and how do we use it. So stage 1 and 2 is around the collect and store. So this means we are acquiring data, ingesting it into the data warehouse, and linking that all together. Stage 3 is the create and catalog. So in here, we're thinking about how to transform the information, catalog it, so then we can understand what we have and use it appropriately. Stage 4 is the inquire and explore. This is where the actual analytics takes place. So once all of that has happened, analysts are able to utilize that data to then do their reports or create the dashboards, which is stage 5. This is presenting the data visualizations. And you might get that in 2 ways. That might be through Tableau, which is how you'll access a lot of the dashboards that we've got, but also it might be via Excel. So a lot of the analysts in Northwest London will also use the WSIC data and create dashboards or information and graphs using Excel as well. So you'll see this data in a number of ways. BI and the analysts in Northwest London are doing steps 1 through to 5. And what we ask of all of you is to think about step 6, is the act and interact. So just to be clear, nobody through steps 1 to 5 is making the decision on what we should bring in and what we should do with that data. This is all driven by step 6. What do we need? What questions do we want to ask? So all those programs, all you individuals out there, what is it that you're wanting to ask of the data, and how do we do that? That's what feeds us into this cycle of what data do we need to bring in, what visualizations do we present. So we really need you to think about how to use that data, what questions are you answering, and what are you going to do with it? It's a lot of the time it's very nice to see a graph and it looks very interesting, but if it's not making a change, it doesn't drive a change in any way, then we have to look at the fit for purpose sort of question. Why is it not making a change? Is it not providing the right information? And you can see how that then feeds into this continuous cycle. As we move through the years, these questions change. So, sorry, next slide, please. So there
5
are a
minutes,
number of
Rachel.
Thank you. There are a number of dashboards and a lot of information out there. So we do find it difficult to be very specific with what do you need to do with a dashboard and how do you use that particular piece of information, what do you do next. That really has to come from within the programs on the floor, thinking about your specific use cases and why there has been a request for that dashboard. But what we do is we create a number of different supporting materials. We have a public facing website which includes all the information about IG, information sharing. We've got all the dashboard user guides. So every dashboard that's created has a user guide. That includes how to navigate the dashboard. So how to find particular pieces of information. It includes from the program, the people who decided that this was going to be the dashboard and what it's going to include. So the owners of those dashboards, they will include an introduction and some use cases, some specific use cases for the dashboard. It will also be really transparent and tell you about what codes, logic, any color coding that's on the dashboard. What does that mean? All of those user guides, which I think is probably the key thing that's really useful to every single dashboard, that's all available on the WSIC website. It's a web page within the ICB website, and I'll share the link to it on the chat in a minute. We also, for the programs, we create QRGs, quick reference guides. So where there is a specific use case and it says, right, if you use this dashboard, click here, go to this, get that. Whatever you're seeing on your page, whatever information you get at that point, you can then do X, Y, Z. Thanks, Rachel, for putting the link in the chat. And finally, we also create videos. And the reason we create videos is it's actually very tough for us to get around and bespokely give people information or training or presentations to every single individual group. So we record a lot. So for example, today's videos recorded, we will put this on our YouTube channel so that anybody who wasn't able to come today can have a look and at the time when they're available. But we do this for a lot of our dashboards as well, and any sort of training events that we do put on. So the YouTube channel is really good to go and have a look at to see if there's anything there that will support you. Next slide, please, because I think this is one of the questions that we were asked was, how do I get access? Well, on here, bottom left of this slide is the WSIC support mailbox. If first place is to really contact WSIC support if you're not sure where to start, how to get access, or even what access do you need. Come and ask us any questions. Absolutely fine to start there. Actually getting into WSIC is much easier than it ever has been. So prior to 2023, there was a username password login, and it was a bit of a barrier to a lot of users getting on and using WSIC in a regular sort of state. But now we have single sign-on. It uses your NHS email credentials, same way that Teams does or your Outlook does. That is what is used to set you up and give you the right access, which means that after the first time of logging in, you're remembered. You don't log into Teams every day. You come onto your computer or log into Outlook every day. It's working in the same way, so it makes it much more streamlined to get onto WSIC. Next slide, please. Do I have the next slide? I do.
Yeah.
Last slide, benefits. There's quite a number of different benefits here. We're going to look at a specific use case in a minute with Narinder. So I'm not going to drill too much into the detail here, but we do have quite a number of different benefits. We're not going to touch on every single thing today with the cancer screening dashboard, but across the wide selection of dashboards that we do have, we can identify and do that sort of case finding, that proactive care piece. There's helps facilitate discussions. It really enables MDTs to work across a holistic view about the what's going on with a population or a patient in particular across the different care settings. You can support your discussions with the patients. So where we've got those individual patient pages. You can download those, print those off, and use those to help annotate. And we've got some use cases where that's happened, particularly with asthma. There's been in practices where the individual asthma patient page has been printed off and used to help explain some bits and pieces with the patient. Reduction of duplication. So because we can see if test results have happened in multiple different care settings, again, it allows the clinician to decide whether that patient is required to have the same test again or not. Understand the impacts of health and social care. I'm not going to drill into any more of that. We've mentioned that plenty of times today. Looking at our population as a whole, so being able to see like where we may have different areas within the population that need specific needs, or how we can help mobilize resource efficiently across the population. And then, of course, finally, the strategic planning and analysis of the population care needs. Last thing I just wanted to mention, Matthew, and apologies, I realise I'm going a couple of minutes over. Before I hand over to Narinda, I'm going to share my page because there was a question about saying I don't know, or something along the lines of people didn't know what's available and how to know what's available. Well, across BI, we have a catalogue, which I'm more than happy to share out. If you've got access to Collaborate, it is available on Collaborate. But for the whole of BI, we've got this catalogue which tells us, we've got data available to you all for lots of different use cases in a number of different places. And across here, it tells us, so for example, in primary care, if you're working in primary care, you don't know what's available to you or what could be useful to you. This catalogue could be really helpful to tell you that there. And if we just scroll on down a little bit further, we've got mental health, learning disability information. This catalogue is going to be really vital to everybody to figure out whether there is something available to you or if there's a need to request a change to a dashboard because it isn't quite answering the questions that you need it to answer. I haven't given you all the details, I'm afraid, today. Bit tight for time. That's because I could talk about WSIC forever, and I tend to do that a lot. But if you do have any questions, we're obviously going to take them from the chat as well. We'll try to answer as many of your questions as possible, but do use that WSIC support inbox email address to forward anything that you can think of, any questions, how to get access, how to get a change to a dashboard, whatever it is, please bring them in and we'll help you wherever we can. Thank you, Matthew. I'll stop there.
Brilliant, thank you. Thanks, Rachel. That's really helpful. Absolutely, as Rachel says, this is not really sort of something that we're just trying to push out in one direction. We want you to sort of have a conversation with us, tell us what you need us to do to help you sort of use those dashboards. So please, do take Rachel up on her offer and sort of use the WSIC intake box as well for questions, because they're there to sort of try and help supporters all do that. Thank you so much for that sort of really comprehensive view of sort of like the WSIC dashboards and creating a really compelling reason and sort of understanding how they can be used. Is Narinda with us?
I am
Brilliant.
here. Hello, Matthew, and everyone else.
Narinda.
Hi.
I'm going to share up the slides. Same process. If you can just introduce yourself and then sort of take us through the slides. Just tell me when you want to go to next slide. I'll give you a 5 minutes heads up towards the end when we come to a close. So I'm going to share the slides, but if you want to introduce yourself, and then we'll crack on.
Fabulous. Thank you. So good afternoon, everyone. I hope you're all well on this lovely Thursday afternoon. So I'm Narinda Sinclair. And I have a few roles. So I'm an advanced nurse practitioner at a practice in central London, and I have a special interest in women's health. I'm also the North West London ICB Primary Care Quality Improvement Manager, working within the Chief Nurses Directorate. And I also do a little bit of work for our Cancer Alliance RM partners as their cervical screening lead across North West London. So as Matthew has said, I'm going to talk to you about how, as a quality improvement team, we have utilised WSIC to provide a sort of a single integrated view of health and care data across North West London, but specifically looking at cervical screening. So the information that we use, it comes down, I'm not going to go into the nitty gritty because I'm not an analyst by any means. But as Rachel said, the data that we utilise comes to us from our general practice settings. And what it does is it allows us to move from reactive to proactive care. So I'm going to present the role that WSIC plays in that decision-making processes and collaboration. And I'm also hopefully going to be able to take you through a short live demonstration of the dashboard if my internet connection is all good and I can share the screen. So we use the dashboard to support us in developing and deliver a cervical screening improvement plan. Next slide, please. Thank you. So what does the cervical screening dashboard do? So it enables to quickly identify eligible cohorts, track coverage rates in terms of cervical screening, and pinpoint unscreened populations or those that may be overdue their cervical screen. It gives us real-time understanding of where uptake is low across practices, PCNs and boroughs, and where support may be needed. It also helps us to think about what interventions might be useful to have the largest and the biggest impact in terms of increasing coverage. This transforms the data into actionable insights that directly supports our clinical and operational decision making. Next slide, please. So the WSIC is a system tool. It's not just for analysts. And we can use it across a variety of teams. So in terms of operational, our practice managers and PCN leads and quality teams can use it to sort of manage how we use that information, like I said, to develop targeted interventions. But we can also use it as in terms of clinical leaders, for our clinicians, GPs and nurses to identify patients for proactive care. But on the other side, our system partners like our ICBs and local authorities, public health, cancer alliances, can draw on it for assurance and planning. Matthew, if you click the button a few times, there should be hopefully some, if I can, yes, there we go. So this, yes, if you go back a little bit, brilliant. But what I do want to highlight here, this is not a performance management tool. And I'll come back to that in a moment. So we can use it at a strategic level to monitor outcomes and therefore support in reducing variation. So it brings together all parts of the system to work together, working from real-time data. Next slide, please. So I just want to talk you through some of the key features. So there's cohort identification. So for example, we can drill down specifically where those people with the cervix in specific age groups or deprivation quintiles who are unscreened or overscreened, or underscreened or overdue a screen. The filter and drill down option lets us have a look at data by practice, PCN or borough. And we can also break it down by factors like age, ethnicity, and long-term conditions. The dashboard presents data through visual charts and trends, which actually makes it easier to analyse and compare across the different settings. And we can also export the reporting functions, so we can use the data for audits, assurance reports or quality improvement projects. We can also use it to monitor progress But like I said, this is not a performance management tool. It is purely to support us carrying out some of those, deciding on those interventions or groups of our population where interventions may be required. Next slide, please. Oh, so hopefully I am going to be able to do a quick demo. So can I share my screen if that's okay, Matthew?
Go for it.
Okay, hopefully this will work. Let's see. Right, can you see my screen?
Yep.
Okay, great. Apologies, I've got a larger screen, so if I'm looking away, I apologise if it looks like I'm not paying attention, but I am. Okay, so for the cervical screening dashboard, we don't need a login, but you do need to be on a secure HSCN network. So for the cervical screening dashboard, you would click on primary care, cervical screening dashboard, and then any of these pages. And it should take you through to something like this. And this is real-time data. So this was refreshed today, as you can see the date here. If you hover over the eye, this takes you through to some of the supporting materials, and there are some really useful videos there. There's a video that I produced alongside the Cancer Alliance, which takes you through how to navigate through the dashboard. So I would certainly advise that you have a look at that if you wish. So where we are currently, we have our screening coverage for cervical screening across the ICB is at 59.5% of screened population, and then it also tells you our unscreened population. This breaks the information down into borough, and then this breaks it down further into the number of practices in that borough who have less than 55% uptake of their eligible population, and then so on. And then you can also drill down into specific practices as well. Using these tabs at the top, you can break it down even further. So you can select different age groups. So let's just say I'm going to look at the younger age group. Always click apply, and this will change. So at the moment, if we're looking at our younger age group, we have 55.2% of our eligible younger age group who have attended for a screen. You can also break it down to borough, and you just unclick and then click which one you want to have a look at. You can break it down by PCN and then also GP practices. If you click on the grey tab at the top, that should hopefully take me through to the demographics, and this breaks it down into very specific cohorts. So you're looking at age, your ethnicity, long-term conditions, and your deprivation deciles as well. If your long-term condition is not displayed here, if you click on the selection at the end there, you've got an option here of all the different long-term conditions. And then finally, you can look at trends as well. So at the moment, this gives you a trend over the last 12 months to have a look at how the coverage has been progressing or otherwise. Because it's not patient identifiable data, that's one of the questions that I do get asked a lot. I'm just going to stop sharing so you can see me. But what this can do, if you want to break the information down, if you want to look at a specific cohort in terms of your population and which cohorts you should be focusing on, you can then use that information, put it into your clinical system, and it should hopefully bring up a list of patients that you would need to make contact with. I hope that helps. That's my demo done. So do you mind sharing the screen again, Matthew, and go back to my slides, please?
Yep.
Thank you. Right. Fabulous, thank you. So I just want to give an example of a specific piece of work that we did with a practice in central London. So this specific practice had a majority international student population. And back in February of this year, the dashboard was demonstrating that they had just over 1,400 patients aged between 25 to 49 that were eligible for a cervical screen. But only 40% had been screened, leaving 60% unscreened. Now, just to put that into context, the ask of the ICB is that we should be at 60%. The ask nationally is 80% of our eligible population should be screened. The practice had various challenges. There was a high turnover of patients, difficulty maintaining accurate registration lists, and limited admin capacity. Through a conversation, two-way conversation with the practice manager and using WSIC, we were able to drill down into identify specific cohorts with low uptake. We agreed some actions, which were to target smaller and more manageable groups using the clinical system to generate patient identifiable lists and to deduct patients as they moved away. This made the workload less overwhelming for the practice. Next slide, please. Oh, has that moved?
Yep, that should have moved, Rinda.
Oh, I don't think it has on my screen. Okay, I'll carry on.
It's not moved on for mine as well, Matthew.
Oh, okay.
Let me just reshare it.
Thank you.
I think maybe if you put it in presenter mode first and then share it.
I'll carry on anyway. So that was back in February. Within 6 weeks of implementing the actions and the changes, the coverage rose from 40% to 51%. And the practice manager did note that focusing on smaller groups made the task feel more achievable. And then looking further ahead, we worked with the practice to build partnerships with the local university student union, and they plan to attend freshers' fairs to promote screening and vaccination. And then fast forward 7 months, when we look into August, the overall coverage increased by nearly 19%. So if we remember, it was 40% back in February, and then in August, it increased to 59%. So that's an increase of 19% over 7 months, just by focusing on specific cohorts and also more manageable actions. So you're not becoming overwhelmed. Next slide, please. So I just want to talk a bit more about quality improvement. So the dashboard provides improved visibility of health inequalities. So it helps us to focus on the core 20 plus 5. It also highlights that there can be variations between practices, and it allows us to direct some of our resources to where the gaps may be the largest. It can support quality assurance with progress monitored regularly via WSIC because the data is refreshed so regularly. But more importantly, what it has done is strengthen our collaboration between primary care, public health, our Cancer Alliance and NHS England. And these insights have directly informed the restructuring of our cervical screening delivery group into a steering group from April this year, with a clearer quality improvement focus. Next slide, please. Thank you. And then I just want to talk a bit about innovation. So the dashboard has supported some innovations, such as the site selection for the HPV self-sampling pilot being rolled out across London in the next few weeks. So by using the WSIC data, particularly the deprivation and age cohort filters, we identified practices with the lowest coverage. And this enabled us to reach out proactively and invite practices who met the criteria for them to express an interest, in piloting the self-sampling. We don't know the results of that yet because the project hasn't been launched. But what this did do, it helped us to drill down into those specific practices who may be struggling to engage with certain populations, so offering another solution to cervical screening. Next slide, please. And this is the last slide from me. To summarise, the WSIC dashboard turns complex system data into actionable insights. It supports both operational and strategic decision making by reducing variation and drives measurable improvements, as seen in the cervical screening uptake. The next steps are to expand its use, integrate new data sets, and then continue embedding it into everyday practice. We are hoping that with these developments, WSIC will remain a vital tool in improving population health and reducing inequalities across Northwest London. So thank you very much.
Brilliant. Thanks.
No problem.
Thanks, Narinder. Thank you so much for giving us that view on a very practical level. Really, really appreciate. Apologies for some technical issues which are still ongoing. Thank you, Rachel C, for stepping in and sort of bringing up the slides, the wonders of modern technology. We're going to come back to the Mentimeter in a couple of minutes, but you know, really, really keen to sort of, we've got Narinder in the room who's a sort of very, very good example of someone who's using the dashboards in a very, very operational way to sort of like help support their planning and their decision making. There was a lot of content in there about sort of how it sort of really shapes some of the thinking around what they're doing around cervical screen. Really wanted to open it up if people had any sort of questions or comments around, for Narinder in particular, around how she's been using the dashboards.
I will just come in and say something while we're waiting. I was not an expert. So my background is purely clinical. And it wasn't until I came into the ICB role, I had heard of the dashboard in my clinical role, but in my ICB role, I had to fall in love with it.
Yeah.
It was really difficult to navigate at first, and I'm not a data person, but actually now I am in love with it. This dashboard, I mean, at first it was really, I really did struggle, but I have to say the support from the WSIC team it has been absolutely brilliant. And if I have any queries, if I have any questions, they are very, very supportive. I think there is some teething problems occasionally along the way, but they're addressed very, very quickly. But we do use a lot of this information to have some of those sometimes challenging conversations with our practices and PCNs. But hopefully we are coming round to them using the dashboard. more to inform some of the work that they're doing as well.
Thanks, Dorinda. I think the key thing here, and before Rachel just comes in, I think, and I think, we hear this quite a lot, and it's wonderful to hear how you've turned that sort of, I'm not a data person, into, you've absolutely turned it around into sort of embracing actually what the dashboards can offer and really seeing the value in sort of how you can use data. And actually, it's not as scary as we often think it is. Actually, it's there to sort of really help, and the WSIC team are there to sort of really help support as well. So it's wonderful to sort of really reiterate that point. It's like, please make a start, because it really does help with some of that planning and decision making. Rachel, did you have a question?
Yeah, I just had one sort of based off what you've just said, Narinda, but thank you for that presentation. It was really great. You said that kind of one of the next steps is expanding the use of the dashboard, and you're sort of going around trying to persuade some of the practices to use the data. I wonder sort of what's your approach to kind of that expansion and persuading people to come on board?
That's a really good question, and it's one that's quite tricky to answer, because this has been, and actually Matthew and I were talking about this when he approached me to present, and the health equity and the WSIC team have, I think before I came into this post, have carried out pieces of work to engage with primary care and general practices to use the dashboard. And it has been challenging, but I think if we have this as a normal part of if we make this the norm and continue having these conversations, then hopefully it will start to embed. Rome wasn't built in a day, but I think we all need to start thinking about what the expectations are from the NHS 10-year plan. It is all moving into population health management and support and targeted interventions that hopefully will be supported by our INTs. And the more people that we have to start using the dashboard and seeing the benefits, I think it can only go up, be in a positive way. So I think it's just normalising the conversations.
Brilliant. Thanks, Narinda. There's a few questions in the chat which I'll come to in a second, but I can see Zabby's got a hand up. And just on a very personal note, Zabby and I used to work together many years ago in clinical services. It's really wonderful to sort of see you here. So welcome, and please do ask your question.
Hi, Matthew. No, I was going to say, Narinda, amazing, great presentation and great example around using WSIC in primary care. So I've also been on a journey with frailty in West London as well, working as a PCN lead. And I have found WSIC's dashboard very helpful tool in my clinical, and I'm a clinician as well, in my clinical practice. And I think also it's very helpful using population health intelligence and data now, because there's lots of talks around neighbourhood health and how those blueprints are going to be mapped out. And I think we have got inequalities around resource allocation across all of our boroughs. I mean, we're neighbours, Westminster and KNC, but I mean, I think it's really good to see some of our GPs are ahead of the game in West London, and they use WSIC's dashboard as well. So, but it's interesting to see how primary care is very varied as well. But I think certainly as a clinician, I really do hope that clinicians do take up this tool. It certainly has helped me support some of my conversations when I have to move people around to different practices. And then also, it empowers you when you're having conversations with individual GP practices, when you have to say, actually, no, you only need someone part-time in this role. It helps. And I think also it helps us to kind of tackle inequalities as well and deprivation. So yeah, so I'm glad you've done cervical screening, but I'm doing something similar for frailty. Thank you.
No problem. Thank you for your comment. That's really helpful, and thank you. I think it's really difficult, and just going back to what Rachel was saying, in primary care, when you are looking at your data, because you are an independent contractor, you're looking at your QOF data, because that is what generates your payment. But the QoF data and the data on WSIC is completely different, because the data on WSIC is looking at actual coverage. Whereas your QoF data, because you can exception report patients if you have made contact with them, let's for example say 3 times, because that's the ask, you can exception report them. That is then included in your QoF data. So there's never going to be the data on QoF, the data on WSIC is never going to be exactly the same. But we are looking at coverage, and this is some of the challenging, I think, yeah, this is some of the challenging conversations that we have to have with primary care, but we need to turn that around. We need to turn that narrative around.
Yeah.
And how we do that, I haven't got the answer, I'm afraid. But if anybody wants to support, then, and it may be that we need to take this conversation outside of here. But I think having that conversation as a system may have its merits and its strengths.
Yeah, no, definitely. And I think now that we know Westminster, Kensington and Chelsea are going to be pioneering neighbourhood health going forward, it'll be very interesting to see how we change the narrative on that, definitely. But I think we're all on the same page, so this is good.
Agree.
Thanks, Sabi. And yeah, absolutely, you know, when we think about sort of the dashboards, this is really for absolutely everyone, and particularly in the concept of neighbourhood health, which is absolutely the delivery mechanism that we're all looking to for the future as our out of hospital ways of like delivering care. It's a really good opportunity to understand how the works of the WSIC team and how dashboards can sort of really help to drive and support some of that work. Just before I come to Kathy, there was a question from Jennifer in the chat just around how the dashboards were funded and how they were how do you fund the build. If you wanted to create a new dashboard, what would that actually look like? So I think Rachel, Matt, that's probably more of a question for you.
Yeah, and it's a really good idea for some maybe future session to go in a bit more detail, but briefly, we do have an internal team that builds dashboards, but we have a long pipeline of requests that come in. The cervical screening dashboard was funded, so additional funding was brought into the team, which allowed us to bring additional resource to do it in a much better timely manner. And that in this case, it came through RM partners, which is no surprise in the cancer screening world. Now, how do we go about the process for creating a new dashboard? Well, we do get a lot of requests in for new dashboards, and we obviously don't just take on any request that comes in. There is a process to go through. So if a individual has a great idea for a dashboard or some questions that need to be answered, usually work through with the program that it's relating to. So with regards to cancer screening, RM partners and primary care work really closely together on all of the requests that they have to make sure that it meets the priorities for them as a program. And then they complete a form which gives the details of what the request is and how we should calculate all those different metrics. And then it goes into a technical sort of design process where the team behind the scenes gets involved to creating that. There's a number of different tests along the way. So we do data validation, user assurance testing, mock-ups of what the dashboard's going to look like. So lots of different steps in between before the dashboard actually gets out there to make sure that it is validated and fit for purpose for the use cases that it's been designed for. But we do encourage people to have those ideas. If you're not sure, say if you know the dashboard exists and you're like, but it doesn't show this on there. So I think there's one earlier about HIU and critical care team. So the HIU program is the best people to talk to about saying your ideas. It would be great. We would start to use this too, and we could really support in the HIU program if we had this information on the dashboard too. So the first place to call is talking to the owners of the dashboard. If you don't know who that is, my team can help tell you who to contact and speak to about those sorts of ideas.
Lovely. Thank you, Rachel. Just before we come to Kathy, yes, I think there was definitely a mention in the chat earlier about the HIU dashboard. So I think there is definitely something around sort of looking to see what's there. And if there is a relatable dashboard, it just doesn't quite have the functionality that you want, please do sort of reach out to sort of the program team and sort of have a sense about what can we do within that space to sort of just try and sort of, rather than invent something new, how can we make what we've got better? But yeah, absolutely. Thank you for that, Rachel. Kathy, sorry for waiting. Please come in with your question.
That's okay. It was just a quick question for Narinder, because you made a point of saying that you wouldn't use your dashboard as a performance management tool, and I wondered why that was, because for us, I would imagine there'll be an expectation to use it that way and to evaluate the effectiveness of our programs.
Hi, Kathy. Thank you for your question. From what I understand, but Rachel, you might be able to help me with this response. So from what I understand, when the dashboard was first proposed and built, it was very clear that it would not be used as a performance management tool, but more so as a tool to support navigating some of our interventions to populations that have the greatest need. Now, when we talk about cervical screening from a ICB perspective, the data that is on the WSIC dashboard is only data collected from primary care, only GP practices. But having, again, and I'm sure Rachel, I didn't join this meeting from the beginning today. But when it comes to dashboards, the data is only as good as what is put in the first place. So if that data is not correct at the source, when it's then pulled, it's going to be skewed somewhat. So NHS England provide more accurate data of cervical screening coverage across regions, but they also then will include any cervical screens taken outside of the general practice or primary care setting. But that data is many, many months behind. But what the WSIC dashboard does, like Rachel was saying and the team was saying, is real-time data, which is what, if we're having discussions with general practice, they want to know, well, where are we right now? They don't want data that's 3 or 4 months behind. I hope that answers your question.
Thank you.
Yeah. And Narinder, I just wanted to add to that, absolutely. And this is, I think, when we're talking about our dashboards as a whole, that the cervical screening is such a great example of how it's used and it's making a change and it's showing lots of benefits. But every dashboard that's created will have different use cases. So sometimes we would look at benchmarking, sometimes we would look at proactive care, reactive, there's different use cases throughout, and it's really coming back to the initial reason for the design of that particular dashboard. You may find additional use cases in it for sure, but the design is all based on the original use case.
Thanks very much.
Thank you, Rachel. We're into the last few minutes. I knew we were going to be tight, and we are. But it's really important that we've got time for some questions. I'm not going to go through the learning outcomes from today again. What I'm going to do is I'm going to hand over to Rachel in a second, just really quickly to have a look and some initial thoughts from Rachel Mack, Rachel and Narinder around some of those initial slight feedback about the poll that we just completed. But I'm just going to wrap up before we do that by saying thank you to absolutely everyone for attending. Everyone is really, really, really busy. They've got jobs to do. So we really appreciate you coming to this, engaging with it, having questions and sort of trying to sort of understand how we're using the dashboards in a meaningful way. This is the first of 2 sessions at the moment. We do want to roll some more out across the year, but this is, you know, we've drafted this based on what we think would be helpful. Please let us know what works, what you would like to know about, what would be interesting to you, because that's ultimately what we want to do. So my fabulous colleague Val, who I think is on the call, will send out certificates of attendance, but also send out a quick feedback. It takes 5 minutes maximum to complete it. Please do let us know your thoughts. We want to sort of make this as meaningful as possible. And on that note, I'm going to say thank you very much. And Rachel, I'm just going to hand over to you for anything final just on the Mentimeter.
Yeah, I thought I would just quickly summarize what kind of some of the main themes were, because it's going to generate more questions back to the group, which you can hopefully kind of fill in some of the feedback or drop us an email after. But there's definitely a theme around more training, more guidance. So I think from that, we'd like to know the training, does that need to be something similar to what we've had today? Is there something different people are looking at for? And the guidance and the SOPs, obviously we've sent a link to all the WSIC guides and videos. So I think what would be helpful to us to know is what is missing from that, what kind of thing that is needed to be different. And then there was also some sort of talk about use cases, which hopefully people have got a flavour for today. And if anyone has any other use cases that they think would be helpful to share and do a bit of peer support, because that was another theme, please get in touch and we can set up another session like this. And yeah, any more feedback on how we can help? I think the Mentimeter are still open, so you can put that in. And yeah, just get in touch. And I'll hand over to Rachel because she's got her hand up.
Thank you. Yeah, I was to confirm, absolutely. Please do check out the videos and the support materials that's available on the website, because from a training perspective, I think that's a really good place to start. I didn't mention it today, but there was something on here as well around having somebody local who could help you out with how to use your dashboards. We do actually run a super user training program. And really it's a bit tricky, I have to be honest, because it's getting the right people to become super users. So those are individuals who would disseminate how they would use the dashboards for their particular ways in their particular care settings. Now we have really good examples of this, and I know we've got HIU colleagues on the call, and they are absolutely excellent at this piece. So I would look at those guys for a good way of being able to do this, and the team are really happy to support with that super user sort of program piece. But do keep putting your comments in there. I just really wanted to mention the super user thing very quickly. Maybe that's something we can take forwards as an item on one of our next sessions to give a bit more information on that as well.
Yep, you took the words right out my mouth, Rachel. Sort of as soon as someone puts their head above the parapet, we like pounce on it completely and go, oh, that would be a really good idea. So absolutely, HIU team, watch out for us. We're coming to talk to you. Just finally, again, just to say thank you so much, everyone. Please do keep engaging with this. We do have another session in October. I can't remember the date. I think is it the 21st or 22nd, Rachel? I can't remember. We will be promoting it out. Yeah, me too. But we've got a date. We'll be sharing it out. We do want to deliver more. Let us know what would be really helpful. And thank you for all your comments already that you've put in the chat and you've offered up. On that, at 36 minutes late, we're going to 36 seconds late, and we're going to finish. But thank you so much for your time. Really appreciate the session today.